Welcome back, guys. So in this video we are going to review pancreatitis. First we will start with the causes. So we have alcoholism, usually the most common cause in males. Gallstones, usually the most common cause in females. Hypertriglyceridemia, more than 1000. Usually it's present with falsely normal amylase. Trauma, poisons and toxins. Medications, we can mention sulfa drugs, all the drugs that contain thia or thio, and steroids, and azathioprine, usually the main causes as medications. Also we have the virals, the mumps usually, and we have genetic causes, anatomic, usually pancreatic malformations and duodenum malformations. Post ERCP procedure, usually we decrease the risk via giving rectal NSAIDs before the procedure, and hypercalcemia because calcium activates pancreatic enzymes. And we have also the autoimmune cause of pancreatitis, which includes hyper IgG4. For the symptoms, nausea and vomiting and severe epigastric pain that radiates to the back, ileus, and sometimes they might mention jaundice. Also, they might mention umbilical and flank ecchymosis. For the umbilical, it's called the Köln sign. See, it starts with the C, so it's in the center, umbilical. For the flank ecchymosis, it's called Turner sign. Remember, you turn at your flanks. For the diagnosis, we need 2 out of 3. Typical pain or clinical image, positive imaging, CT scan or MRI showing the pancreatitis, and positive labs, amylase and lipase, more than 3 times the upper normal value. So usually for the labs, we order lipase and amylase. Usually they are more than 3 times the upper normal limit. Calcium and triglycerides. We order gallbladder ultrasound for all the patients, even if they are alcoholics, LFTs, and CBC, and the usual normal labs. For the CBC, it might show hemoglobin hemoconcentration secondary to third spacing. Now for the treatment. The cornerstone of the treatment is to give IV hydration aggressively. Usually the patient are given normal saline or ringer lactate. Then to control the patient pain, which is very essential. 3, to place the patient MPO. However, this is only done at the early stage of treating pancreatitis. As long as the patient has no pain or can't tolerate oral intake and has no nausea or vomiting, then you should start giving oral feeding. And of course, you have to treat the underlying cause that has led to the pancreatitis itself. Usually, it's very important to know this information that we do CT scan or MRI to detect the percentage of necrosis. If it's more than 30, then we need a needle biopsy to get a tissue, and if the patient has infected necrotic tissue, then we need to start antibiotics. Usually we give carbapenems like meropenem or ertapenem. Also, it's worthy to mention if the patient has necrotic pancreatitis, then this patient needs a surgical consultation. Thank you guys for watching. Good luck on your preparations.